Hello everyone, welcome to Ardexia Insights. I'm Dr. Aditi Joshi, and this is where we cut through the hype to explore healthcare innovation that actually works. Each episode, I talk with leaders and practitioners from around the world, navigating digital transformation, whether in telemedicine, AI, RPM, and system changes. We share real stories from the trenches and practical strategies for creating healthcare change that people can trust. So let's dive in today. Today I have my friend and colleague, Dr. Resa E. who is a Harvard-trained emergency medicine physician with expertise in healthcare design and technology integration. She has designed point-of-care ultrasound programs with EHR integration across multiple healthcare systems, delivered a TED-Med talk on technological disruption in medicine, and served as a healthcare physician designer with Perkins & Will architecture and design firm. Her work includes ICU redesign at Beth Israel in Boston, and an infection control unit in Malawi, integrating principles of human-centered design to optimize built environments, workflow devices, and patient care spaces. Her experience across 6 continents provides a valuable perspective, a diverse perspective, and I should say also she has been innovative in the spaces of POCUS as well as healthcare design. So it's so nice to have you here, Resa.
It's great to be on with you.
All right, Resa, when we talk about healthcare design and the idea of putting that in systems change, I don't think a lot of physicians or other clinicians realize how important that really is. So I wanted to ask you just about how did you, and what do you find important about talking about healthcare design? And then on the other side, why is it important to have this bridge rather than just leaving it to architects who are the ones who traditionally think about physical spaces and design?
This is such a great question. Thanks for that question. I'll talk a little bit about my design origin story. It happened in Denver, Colorado, at the University of Colorado when I was working there in the Department of Emergency Medicine. And you shared with the audience about system design and hospital systems and EHR integration. And specifically, my lens has been through POCUS, point of care ultrasound, because ultrasound is not just this isolated tool that we're using, although I think some people would prefer it were, but it's integrated. And at the end of the day, all of us who really believe in POCUS, it's because of safe, patient-centered care. So when I was at the University of Colorado, colleagues put me onto a conference that was happening at Stanford X. And I attended, and then I returned the following year and presented. A very novel thing happened. They had a patient on stage speaking about their experience through a moderated conversation. And this perspective of the patient, the end user, the end recipient, I was like, it seemed like rocket science, but it's so simple. And to tie it into your question about the built environment and our physical spaces, any of us who have worked as clinicians have certainly, been the recipient of, a brand new ED, or, we changed the table where the computers sit and it's either too short or too tall, or every time we round a corner, we bang our knee. Those are design challenges and things that haven't necessarily been worked through. So this concept of having the end user at the table, be it a patient, be it a clinician, because we're going to be working in a physical space, be it a mom or another caretaker who's going to be the one administering medicines. One of the first healthcare design studies that I read was about asthma patients in Chicago at a pediatric hospital. And there was almost a blaming the victim. Patients would come to the emergency department, children accompanied by caretaker with asthma exacerbations, and then meds wouldn't get filled, and then there would be returned to the emergency department with an ongoing asthma exacerbation, as opposed to actually looking at the why. And so the great thing about health design, healthcare design, people use terms interchangeably, is you really get all stakeholders and many perspectives at the table. And so if you have a problem or a question or even a device that you're trying to design, rather than coming up with an end product, the concept of healthcare design thinking is take that question, take that device, take that design problem, and brainstorm. Brainstorm on a big whiteboard or however you want to do it, a Miro board online, about what should we consider, what should be the solutions, what should be the specs of this, we'll say a device, like an ultrasound probe, for example. And then iterate, ask questions, and have, sure, the clinician, the emergency doc at the table, but how about the patient that's going to be having the probe placed on their body? How about the engineer? How about the person that actually works with material science that has to talk about the plastic and the coating and the crystals at the head of the probe? How about talking with the ultrasound companies who are used to designing for like radiology suites, but now actually this is going to be a portable type of device, so it's going to be handheld ideally or much more portable. So there's all these different people that are part of the design process that ultimately is going to be an ultrasound machine that's going to help deliver patient care. And I didn't even mention information technology and, the software solution to help get those images from the machine to an imaging place that around the hospital, everybody can look at those images. And then that's part of the integration with the electronic health record. Oh, you need to document it. Oh, and if you're concerned with coding and billing, you need coders and billers. Like there's so many people and some are way down the line. But if you have everybody at the table early on in the process, your ultimate product may not be perfect. It won't be perfect, but it'll be a much better device than had you not had those brainstorming sessions, those iterations going back to brainstorm, iterations going back, and then ultimately the product. And so I just thought, of course, that's why this sort of, why don't patients take meds 4 times a day? Well, it's really hard. In fact, there's a very famous experiment, it was called the jelly bean test, where people that were part of the study, I think they were in business organization leadership, were tasked with taking 4 jelly beans a day, different times. And they couldn't do it. Like basically everybody had abandoned the project after a few days. In other words, it's hard to take a medicine 4 times a day. So the blaming the end user as opposed to involving them in the design just makes sense. And whether it's ultrasound, whether it's AI, whether it's designing an emergency department physical plant, having everybody there just makes sense. We could even point to, I'll use one more design, then I'll stop, scrubs. Now there are many companies of scrubs, many shapes, many sizes, many designs. But, the scrubs that I wore when I was coming up in med school and residency, those scrubs weren't cut or made for me. I mean, they certainly weren't in my size. I had walked on my scrub pants a lot because they were so long. Anyway, design is everywhere. It's more that we have to open people's eyes, ears, nose, throats, and sensory perceptions to see that everything is designed and we can play a role in that design. In fact, it's fun to play a role in that design.
Yeah, that's so interesting. And you're right. And we've talked about this where this is true for all parts of the healthcare system, but even as physicians, there are things that we just do, even if it's not an easy process, just to get through our shift or get through the day that we're trying to have. And so when we're talking about innovation, so taking this entire idea, now when you're bringing in digital tools, you are bringing in a company that has created a digital tool, whether it's AI or telehealth. You may or may not have had some input on that process. Because when you talk about healthcare design and the process of healthcare design, it's very similar to the way that tech companies actually build out products. But now we're talking about integrating it into a clinical space. So when you have those experiences where something may come in already built, how do you actually take that design process and make it work so all of these multiple humans with the competing need in the healthcare space, how do we make sure that they still fit into that?
It's a great question. I have been the recipient, I think we are the recipients being having trained in medicine and then working in the emergency department, we're the recipients of design that's just sort of presented to us and we adapt. And as you noted, we're very, very, very adaptable. One thing I found with these different ultrasound sections that I've been a part of at different institutions is the more frequently you change a process and a workflow, the more you're at risk of losing people. And people are like, I don't even remember all these changes. What you think is a small pivot or a small step change can be overwhelming, and it can be enough for people to be like, to abandon the technology. And it's not only ultrasound, but that's been my experience. So that thought process, that system design process should be thought about in terms of workflow. And so if I'm basically given a new EHR and the hospital system is like, this is your new EHR, go for it. I think there's a few and there's a whole process of keeping things in beta testing and then rolling it out. But if I'm overseeing a team and there's something new that we're dealing with, again, let's make believe it's a new EHR, I think there's an education component. There's a, sort of dress rehearsal before it goes live component. Then there is a, have your coach beside you component. And then there's an ongoing evaluation and training component. So there's a multi-stepped process, and that multi-step that I just outlined was sort of something I've just off the cuff about how things I've seen integrated. I think when things are organized and rolled out in a very clear, processed way, there's more chance of success. But what we see in healthcare often is we get an email of like, oh, we're all starting this now. And, there's some quick change. What if people don't check their email? What if people are coming off the night shift or are sleeping? Like, there's all different reasons why new rollouts, be it a software, be it a device, be it a process, can fail. And this even goes back to having your team at the table and making sure there's announcements. I think one of the most successful rollouts I've seen is when the announcements start 6 months ahead of time. And there's a reminder at every faculty meeting. And then there's a demonstration. And then there's maybe an online tutorial. And then there's, the online quiz you have to take. The reinforcement and the repetition, because people are busy and there are many things that people are balancing in their professional lives and in their personal lives.
That's so true. I mean, we've talked about it a lot. And as you know, what I work on is exactly this problem of adoption, because what you're talking about is that if you don't have this type of design or thinking or recognition of how things are implemented and the real human aspect of clinical workflows and the clinical experience, you're not going to have success in rolling out anything that you want to do. Obviously, we're talking about maybe digital health or technology, but this can be true for anything. So, I'm just curious, like when you've seen that, because you also work, you do urgent care, emergency medicine, and telehealth, right? And you've done studies on how one can and patients can use POCUS in remote spaces. So they're, very different care delivery models. And when we're talking about the adoption, and let's say that in this example, you're talking about now that we're going to start using POCUS in a remote space, what would you, and how would you, or what have you done to think about how do we make sure that it does work as a process, just as a more practical aspect for people who are trying to implement this into their practice?
I'm going to hat tip a study that you and I were both a part of, where for the audience, we were trying to do a proof of concept. We know, and actually COVID really taught us a lot, that, the in-person may not always happen, but also it may not always be necessary. So what if a patient who has no experience, no exposure, no training in ultrasound is sent, mailed, given an ultrasound probe? Can they be teleguided to actually obtain, put the probe on parts of their body, either through instruction verbally, even through a visual, even through maybe seeing bright lights on the screen like green light, yes, red light, no, to get images that the clinician on the other side of the screen can actually say, yes, that is a interpretable image, and I can see, for example, there's no fluid around the heart. This concept of, hospital at home, care at home, trying to keep patients out of the hospital if they don't need to come to the hospital is sort of like win-win for everybody, certainly the patient, but definitely the healthcare system. So that proof of concept, we had very well patients in an outpatient clinic who agreed voluntarily to join, and we just did this proof of concept. And the summary of what we did was that people were able to follow verbal instruction and obtain images that were interpretable. We haven't gone to the next step with that study, but what's important in terms of who we need at the table, what we need at the table is there are a lot of assumptions about able-bodied, in terms of eyes, in terms of comprehension and hearing, in terms of manual dexterity. And I've seen this a lot with my in their 80s parents, their ability to navigate technology. And it only catches you when you see how difficult it is for certain communities. And so if I were designing something, I would definitely have elders at the table to give their input in terms of technology. Like, we love it. We eat it up. But it's really humbling to see, like, after a certain age stage, or again, able-bodied doesn't have to be age-related, people can't integrate the technology, which means ultimately it's not a human-centered solution. It's not going to work unless ideally it works for everybody.
Thank you for bringing that up, because it also speaks to the idea that when we're trying to talk about technology, an example that you were giving, and even the study, the whole proof of concept, the idea was that people don't have access to these tools. They don't have access to the doctors who can do these types of studies, or the technologists who can do these types of studies. And so how do we actually get them to access it? But we still have some of these other barriers that still create a lack of access. Can't actually get them that technology. And so it's really an important thing to think about, is that, every single end user, like you're describing.
I was going to add that thanks to you and your educating me regarding telehealth and you and I having a lot of like spitball conversations, brainstorms about telehealth, like I learned that not everybody actually could figure out how to get on a screen, in which case it was a telephone call. Like it was a very great educational and patient care centered experience to do telehealth. I loved it.
I'm so glad. I'm always happy to hear when people love telehealth, and it was so fascinating to learn about the POCUS, because also I have only done it as a resident and training and doing it as an attending, but figuring out how to do that remotely was really exciting. And so one thing I want to add, because when you talk about POCUS and we're talking about this idea of access, you've also done this around the world, right? And so when we think of technology too, and this is a given, is that we have technology being developed all over the world. And often a lot of the companies want to either expand globally and go to other spaces. And so I'm curious, when you are thinking about it from a design, from a technology, and a human perspective, what do you see that actually translates easily? And what are the actual barriers for making these technologies and these clinical workflows cross context successfully?
To give listeners some background, when Aditi shared that I've been on 6 continents, it's teaching ultrasound, POCUS, workshops that would be anywhere from 1 day to 1 week in all parts of the world. And so some non-starters, I always ask, who's the audience? Like who is going to be attending this? You know, it could be sometimes doctors, commonly it's midwives or nurses, sometimes it's outpatient community workers, like it's understanding the role of the people attending the workshop. Next is, what is their most common presentation? What applications do they seek to learn because of patients and patient complaints? For example, outside of the US in general, people haven't been as interested in an aorta ultrasound. The concept of AAA, like it's a lot of sort of non-communicable diseases that aren't always the main disease presentations at other countries where I've visited, taught, educated, and worked alongside healthcare professionals. So it's always important to me, like, what are their goals? What are they seeking to learn? The other thing that I have really loved about the education around the world is you realize that there may not be a CT scanner, there may not be an MRI. There's almost always an ultrasound machine, usually in the corner, usually not plugged in, usually hasn't been turned on for years. There is this we don't realize that clinicians, not just radiologists, can use ultrasound. So it's very empowering. And it's also, in terms of places where there may not be as many resources, it's generally affordable. Yes, you need electricity, and there are actually solar-powered machines, but thinking about electricity and surge charts of the electricity to make sure the machines don't blow out, because actually on the end of that, maybe in this country we can have a rep come and they can swap out a probe, swap out a machine. That is not at all easily done in other countries where, sort of ultrasound companies' staffing is more sparse. So ultrasound is basically a much more affordable, practical tool in many places without the same resources as some of the very resourced countries. And so the aha moments that you experience alongside these other healthcare professionals that are taking the ultrasound courses is amazing. I think thinking about and what gets built in is maintenance and troubleshooting when the probe or the ultrasound machine does go wrong, because we may call up 1-800 fill in the blank company. That's not always possible in other places, and it's not as easy to just get a probe swapped out. So machine care and upkeep, as well as a way to review, because again, getting a software solution and having like an EHR is not sort of possible, and it's not what's been integrated at many places where I've taught. So talking to them and actually having a segment on a quality assessment, quality improvement workflow. Like, are you going to snap pictures on your smartphone and send it to someone and we'll review them every week? Do you want to do a live Zoom conference once a month? Like, thinking about not just this one and done workshop, but a sustainability plan. The most successful experiences I've had is when the sustainability plan has been talked about, designed with the people that are going to be the one to kind of own ultrasound when we leave, and to make sure there's ongoing communication once we leave.
Yeah, there's so many incredible nuggets in that, but basically, I want to tell you for the audience that Resa was one of the innovators and starters of POCUS, or point of care ultrasound in emergency medicine, which significantly changed our practice for exactly those reasons, that it is available almost everywhere and can do quite a lot of work. But it's interesting because when you're talking about it from all these different contexts, some of the same principles apply where you actually have to understand who's there and you have to give ownership and leadership to those areas. It is absolutely not useful for any adoption or implementation, digital tools included, to go in, implement it, and then just leave, which tends to be how a lot of people do it. You actually need those people on the ground who are going to continue the program. Otherwise, they'll just fail, or it just won't even work from the outset. So I think that's a really important thing to stress about what you were also talking about. And so for our last quick question, I wanted to stress everybody should look up Resa's TED-Med talk on technological disruption in medicine. And I know that was a couple of years ago, and I'm just curious, how has your thinking evolved about what disruption means in healthcare? And what would you say that is updating your definition of what disruption might mean in healthcare, or has it been the same?
I love this question. That year, which was 2014, it was called, I think, a disruptive innovation, ultrasound disruption, but this catch term of it's a disruptive innovation, it's a disruptive innovation. It was like everybody was throwing that term around. And I joke sometimes when I give lectures, it was like the same year, all of a sudden, every single coffee shop started having avocado toast. Like avocado toast became trendy and everything became a disruptive innovation. And so, what that experience taught me, is storytelling. And I completely changed the way I presented from that experience forward. And what I love is storytelling is 100% a part of healthcare design. In fact, that's often how we get people's attention. It's how the companies understand why the technology doesn't work, why it does work. And having those live stories, even going back to what I shared about the Stanford X, having the patient tell their story on stage, it's just like, it just conveys so much more. So I still think as we've progressed with ultrasound and sizes have gotten smaller and more portable, as AI is now everywhere being integrated, and sometimes responsibly, sometimes less responsibly, but I believe we'll get there, and I believe in what AI can do for healthcare. It's always about the stories. It's really going to be about the stories. And one thing you shared about the one and done, the in and out, one of my first experiences doing global health and teaching emergency medicine, I was a resident doctor and I was assigned to talk about C-spine injuries and immobilizing the C-spine. And the lecture was sort of given to me, and I was a resident with these faculty, and I was just appreciative of going on the trip. But it was such a bizarre experience because the lecture sort of didn't at all take the temperature of where we were going and the community we were going to help these healthcare professionals serve, and the fact that these healthcare professionals knew the same information we did, but advise in a healthcare talk like you should just put on a C-collar. They didn't have C-collars. And in fact, they had sandbags with tape. And, there was, so I think it's, being aware of with whom you're speaking, who you're teaching, what would best serve them, and not making that assumption that you know best. We have to walk humbly because of the iteration process, of the design process, but part of that is bringing those people to the table. So circling back, I have continued to see the value and the importance of stories, and that telling the story can illustrate your point and be memorable in a way that any chart of data doesn't really stand up to.
This reminds me of the old adage of you should keep curious, and that's the only way to keep growing and building and really making effective change. That's really a great answer. And I'm looking forward to seeing what might happen in the future in 10 years to ask you again what you see disruption in healthcare. Because who knows where we'll be with all of these new digital tools that we have. And I want to thank you for joining me today, Resa. It's always a pleasure to see you. I always learn a lot when I talk to you. And for the audience, thank you for listening to us at Ardexia Insights. If this conversation sparked ideas about your own healthcare innovation challenges, follow along. We have guests from around the world who are building innovative healthcare that stabilizes societies and makes for better patient care. So until next time, thank you all very much. And thank you, Resa.
Thank you.